Mitt namn är Anders Fasth och jag är seniorprofessor i ämnet pediatrisk immunologi. Det betyder barns immunologiska sjukdomar. Det kan variera sådant från sådant som inte kan försvara sig mot infektioner, men också där immunsystemet inte fungerar som det ska utan ställer till det i kroppen. Till exempel kan ge ledgångsreumatism eller inflammation på andra ställen i kroppen. Och jag har kommit i kontakt med barnen med PANS eller PANDAS just i min egenskap av immunolog.
Anders Fasth, du har jobbat då med patienter under väldigt lång tid, 50 år. Och för första gången träffade på PANS runt 8 år sedan. Var det någonting som överraskade dig i symptombild hos de här patienterna när du först träffade dem?
Egentligen inte mer än det hastiga insjuknandet. Det här att när man träffade på så kunde föräldrarna säga på dagen, ja i vissa fall till och med nästan timmar när de blev sjuka.
Just det.
Men annars hade jag funderat kring inblandningen av immunsystemet på sjukdomar i nervsystemet sedan länge faktiskt. Jag tror faktiskt ända från mitten av 80-talet då jag uppmärksammades av vår dåvarande professor i neurologi på området, och han faktiskt skickade mig på en konferens om neuroimmunologi.
Så för dig var det inte främmande att infektioner kunde skapa den här typen av felriktat immunförsvar och därmed ge svåra psykiatriska symptom? Det var
Nej, egentligen inte. Det var det inte, utan jag blev snarare nyfiken och ville veta mera kring det hela.
Och vad tror du har varit utmaningen? För alla har ju inte accepterat det faktum att det här infektioner eller andra saker då kan innebära ett immunförsvar som reagerar annorlunda. Vad tror du är hindret att folk inte vill ta till sig den kunskapen?
Jag tror att en del är att man jämför med vissa andra neuroimmunologiska sjukdomar och där vi har en markör. Vi kan hitta en autoantikropp till exempel, och det har ju hittills man inte lyckats vid PANDAS. Och jag tror att det är en stor anledning till att många barnneurologer och även barnpsykiater inte vill acceptera diagnosen.
Så vi behöver alltså fler forskare som gör ett skickligt arbete inom det här fältet och mer resurser. Ser du att det alltid finns en autoimmun aspekt i det här, eller tror du att det kan variera utifrån individ?
Eftersom vi inte vet orsaken idag så är det väl rimligt att se att det varierar. Man har ju dragit mycket slutsatserna från PANDAS, alltså att streptokocker skulle vara orsaken, och likheten med Sydenhams korea med reumatisk feber. Och det är väl rimligt som en modell. Men alla andra infektioner, ja där behöver vi mera och en bättre förklaring hur de skulle kunna trigga och utlösa det här typiska insjuknandet.
Vem tror du har bäst verktygslåda? Vilken profession eller vilka professioner behöver samverka till de här patienterna?
Jag tror inte att det är en profession. Jag tror att det handlar om dels de olika kliniska professionerna, barnpsykiatern, barnneurologen, immunologen samarbetar som något exempel. Men sen så skulle jag också gärna vilja se några djurmodeller över sjukdomen. Om man där kunde komma närmare förklaringen. Och då har vi ju basal forskning helt enkelt inom i neurologi och immunologi. Så får vi hoppas att vi förstår bättre.
Så, och fram tills dess att vi vet allt så behöver vi förhålla oss till den beprövade erfarenhet som vi just nu har. Och då behöver vi professioner som bistår i de här fallen. Det är så jag tolkar det då.
Och ha ett öppet sinne för att se patientens symptom och vad vi kan göra i dagens läge.
Och vi har ju många, liten avslutande fråga, vi har ju många som svarar otroligt väl på högdos IVIG. Och det pågår ju studier nu runt om i Sverige. Vill du säga några ord om det och förhoppningarna kring det?
Det finns, när det gäller intravenös immunglobulin, så finns det 2 randomiserade studier och de är tyvärr inte gjorda enligt full vetenskap, så man kan inte dra slutsatser från dem. Och då har det tyvärr blivit så att de som är för säger ja, det finns bevis för att det fungerar. De som är emot säger att nej, men vi har inga bevis för det hela. Sen finns det en rad anekdotiska rapporter om att det här fungerar. Det finns också en god pilotstudie där alla patienter har fått det, men de har varit mycket rigorös vad det gäller olika skalor att använda. Och det pekar på att vi ska kunna nå ett resultat. Och nu görs alltså en randomiserad studie på många håll i världen med en sponsor och som är mycket rigorös. Det måste den vara, men jag tycker samtidigt lite synd om patienterna därför att det är få som möter kriterierna för att vara med. Man måste ha insjuknat till sista 6 månaderna. Och tänker vi på att det kanske tar 3-4 månader att få diagnosen just genom att den är obekant och det blir många besök hos barnläkare, barnpsykiater innan man sätter diagnosen, och plötsligt står vi där och har bara en månad på oss att inkludera patienten. Men jag är väldigt förhoppningsfull om att den här studien ska kunna ge svar på om immunglobulin gör nytta eller inte, och att vi får slut på den diskussionen tack vare det.
Hello, my name is Michael Daines. I'm a pediatric allergist immunologist. I'm the co-director of the Children's Post-Infectious Autoimmune Encephalopathies Center here at the University of Arizona. The Children's Post-Infectious Autoimmune Encephalopathy Center deals with children that are having post-infectious reactions that are impacting mood, movement, and behavior. These would include disorders such as PANS and PANDAS, which are part of this family of problems.
So you see that this is a big impact on the family and the siblings.
It's got a huge impact on the family and the siblings. It's like throwing a hand grenade into the middle of the dining room table. The children become very needy. They have tremendous anxiety and OCD that impacts everything that the family is trying to do. And even when medically we treat the inflammation and get them on the road to being better, there are still steps that need to be taken with therapy to try to help them understand what they've gone through, and then teaching the parents how to parent these now somewhat damaged children until they can get completely better.
Have you developed your own strategies for this patient group?
Yeah, so I think the problem is if you approach this purely from a psychiatric or behavioral standpoint and don't treat the medical part, you're dooming yourself to failure, because they're still going to have that inflammation driving things. They're still going to have the same problem that their innate biology is causing them to have this. But going the other direction, if you only treat the biology and ignore the psychological and behavioral impacts that it has, you're never going to get the children back completely to where you want them to be. So we use a multidisciplinary team approach to try to get these children completely and comprehensively better.
Why do you think a lot of people, also in the profession you work, why people don't believe in the disease? Is it also that in your case, in your country?
So I think belief is something for religion, not for medicine. I think medicine needs to be based on data, And there's good data to support this. Dr. Sweeto wrote up the first 50 case series in 1998, I believe, and had a very defined group of patients that had a matching set of symptoms that they showed up with. And so this is a clinical diagnosis, which means that there isn't a laboratory test or an X-ray or a biopsy or something that verifies it. It's based on a spectrum of clinical illness. And we have a lot of clinical diagnoses in medicine that we take care of. No one diagnoses bacterial otitis media, which is just an ear infection, because to do that, you would have to put a needle into their ear and aspirate the fluid out and culture it. Instead, when someone shows up with a fever and a red swollen eardrum and pain, you treat them with antibiotics. And this is the same kind of thing. We know what the clinical presentation is of children that have this. And so based on that clinical presentation, we try to treat them and get them better as quickly as we can.
What would you say is the dangerous part if you don't diagnose and treat these children? If they get ill and will be ill for a long time before they get help?
That's a good question. So there are the children that we see that we diagnose early and that we have that acute, very sudden onset of symptoms. Those are the ones that respond best to the anti-inflammatory treatment, and those are the ones that need less of the ongoing therapies because they don't have as much of a negative impact of the illness on their life and on their family. The children that have had this chronically, either because inflammation is no longer a part and you're actually dealing with damage to the brain, or because the psychological and behavioral changes have ingrained themselves into what the patient is, are much harder to treat and are much less likely to get a full recovery.
So there is a good hope for those kids who we take care of immediately, is what I'm hearing. And I also hear it's very important to do that so we don't have the full length of consequences.
Absolutely. Early recognition and early diagnosis and early treatment are the most important things. And I'll be honest, the recognition is the hard part because it isn't something that people think of off the first part of what they're doing. And so if you don't have people that are aware and are thinking about it, these kids will just end up in behavioral health or in psychiatry or in somewhere else where they don't get the biology treated that they need.
You also recently had Dr. Gillberg and his team visiting you.
Yes.
Can you please describe a little bit about it? We have also met them here today during this hearing. Yeah.
Yes. Well, it was wonderful to get a chance to meet them. My mother is Swedish and goes back every year, so it was nice to have a chance to talk to them. They're a wonderful group that I think are building a very good program. You have a very different water to swim in than I do, and I think there are going to be some unique challenges to building out a multidisciplinary clinical approach to take care of these children. But I also think it's a moral imperative to do it, because if you don't, you're going to be dealing with these children as long-term psychiatric and behavioral problems, which is going to be far more expensive and far more traumatic on the child and far worse for the family than the early diagnosis and treatment would be for them.
So I know it's a really hard question to answer, but how many kids are there out there? Do you have any estimate?
So I'll answer that with a story. So when I so I'm an immunologist, and I take care of patients with immune deficiencies, including SCID, severe combined immune deficiency. Okay, that's the bubble boy disease where they have to be isolated from everything. Okay, when I started, we thought that the incidence of SCID was 1 in 250,000 people to 1 in 500,000 people. Okay. We started doing a genetic screening test on newborns to catch everyone that has this, and we found out that it's 1 in 25,000 to 1 in 50,000. So there were 20 times as many people that have it than we thought had it when we started. And in SCID, that means those children were probably dying because they were getting infections and not making it to the point where they could be diagnosed. So without a screening tool, it was impossible within a factor of 20 to estimate what the rate of severe combined immune deficiency is. And the same thing is true for PANDAS and PANS, because they are clinical diagnoses that need physician awareness in order to make the diagnosis. And without that physician awareness, any number that I give you would be a guess.
But probably more than we know.
Definitely more than you know, because you're not looking for it. And if you don't look, then the answer is zero. It doesn't exist. So yes, it's significantly underdiagnosed, I think, especially in areas where children can be blamed as being a behavior problem and moved off to the side.
Do you think we have a case where children have the wrong diagnosis because we don't have the knowledge to take care of this clinical diagnosis?
Sure. So, and this is a clinical diagnosis, so no one's perfect in putting people into a clinical diagnostic category. And so there is a possibility that we both over and underdiagnose people, but I think that a skilled team using the appropriate diagnostic criteria is a very accurate way to assess these things. But if you're looking at just outpatient general pediatricians or family practitioners, without being able to have the guidelines in front of them and think about it, I think there are a lot of kids that are getting missed along the way.
So from your perspective, how is the immune system playing the part, and can we see in the long term some other medications that's not IVIG or plasmapheresis, or is there something else in the toolbox that we could use in the future if we understand the immune system better?
Yeah, so the immune system is tricky. You can't suppress just part of it. When you give something, you suppress everything. So nothing is free, okay, and that's a problem. We do know that for kids with PANS and PANDAS, that anti-inflammatory medications can be helpful. And so for kids that are having acute flares, Stanford's done some research showing that medication naproxen is effective for shortening the duration of those flares and decreasing the severity of those flares. We will use antibiotics to treat infections to stop the ongoing stimulation of the immune system. And we will sometimes use antibiotics that are anti-inflammatory themselves. So azithromycin has been used as an anti-inflammatory in cystic fibrosis and in other diseases, and so we'll use that as an anti-inflammatory sometimes. We also use prednisone as a steroid to try to decrease the inflammatory response. So all of these medications are in our toolkit and are all things that we use. All of them have different side effects that can be problems with long-term use, and so we monitor patients carefully that are on any of them. We do believe in being good antibiotic stewards and using antibiotics as little as possible, but if needed, we use them to treat these kids to try to get them better.
Also for long-term if it's needed, if they respond to it. Yeah.
Of course, yeah. I think there are several unknowns here that really need to be worked on. I think knowing the incidence of PANS and PANDAS would be wonderful. But in order to do that, you need education and outreach to primary care doctors and school nurses and to the people that are emergency room doctors, people that are going to be on the front line, that are going to see these kids before their symptoms progress. So the research question, what's the incidence, needs an education answer so that you can actually find out the answer behind that. There's a lot of research going on looking for biomarkers because there are people that have problems with this being a clinical diagnosis. And so there are several groups that are doing biomarker research to try to get something that would be able to say yes or no with this disease with a blood test instead of having a hour and a half interview with a psychologist. So
exactly. Can you give us some special insights for success? How can we learn from you in Arizona and your clinic? What do you want us to take with us here today?
Well, building a clinic like this is, to be honest, expensive and requires the buy-in of a lot of people. You have to have, the first thing you have to have are practitioners that are willing to do it. Because if you don't, no one can make doctors do things that they don't want to do. And so you have to have doctors that are interested and are involved and want to be part of it. And there are different tools that you can use to get them interested and involved. So in our center, we use it as a center to do research and outreach and education, which are all parts of what our jobs are. And so that's where we come into it. The other things that we needed to do were to have buy-in from the people that run our healthcare facility. And that came from several different ways. We got some funding through one of our grants for our nurse, so that we have a full-time nurse she's the front door to our clinic, and so everyone gets to meet her, and she's wonderful. But if we only had a part-time nurse or somebody that was, a mixed group of people, it wouldn't work as well, because these patients and families are complicated and desperate sometimes. So we really need to have somebody that can address that. So having that helped our healthcare institution to buy in, and then our medical school likes it when people do research. And so when they saw that we could use this as a research tool, they were fine with it. So once we had buy-in from all the people that pay our salaries, we had a pretty easy time getting the clinic set up. And it is a well-known clinic, and it's a little bit of a halo clinic, if you want to think of it that way, in that people see it, they know the name, and they think good things about it, and by extension, they think good things about the institution that is supporting it.
And the most important of this is that you see results. You are helping these children and their families.
I just wish we could see more children, actually. But we've had some staffing changes that have slowed things down a little bit. We'll fix that eventually. But it's just hard to keep everybody together and moving forward, because it's also a lot of work. But in the end, yes, I think it's very valuable, and I'm glad we do it.